Hi, guys. Today we're going to talk about chapter 56, which is about the placenta. Now, when we're doing this placenta chapter, I just want you to be aware that your placental test next week will not be open book. So make sure to take notes and pay attention throughout this chapter. A little bit about the embryogenesis of the placenta. There's multiple decidual changes right when the embryo implants into the endometrium. The decidual reaction, which we want to see in the first trimester, which appears as a very achogenic ring around the gestational sac, occurs between the blastocyte and the myometrium, and that's the decidual basalis. The decidual capsularis reaction occurring over the blastocyte closest to the endometrial cavity. And the decidua vera is the reaction except for areas beneath and above the implanted. So there's multiple areas or that are labeled different that become the placenta. This is kind of what we're talking about here. Um, the cervical canal, the embryo is implanted into the endometrial cavity, and the decidual vera is every place that is not exactly where the embryo is implanted. The decidual basalis is the maternal side, and the decidual capularis is the more of the embryo side. Picture. This is the little embryo within the amniotic sac. Yolk sac right here. So the fetal chorion, the chorion frondosum, it forms the fetal part of the placenta. And I want you to know that for your test. The chorionic plate is the fetal surface of the placenta, and the basal plate is the maternal surface of the placenta. So both of those things are important to know. So the placenta, one part is facing the baby, and the other part is facing the uterus, basically. So there's two plates that help to make up the placenta. The placenta is also very vascular. Um, and these are the little arteries that are coming and going from the mom to the baby, basically. So this is the myometrium. So that you remember that's part of the uterus, the muscular part of the uterus. The decidual basalis is this part right here. This is more of the chorion. So all of these veins and arteries, these little capillaries, basically, they and venous sinuses and spiral arteries, they are transporting blood in between the mom and the baby. And here is the amnion and the umbilical cord, the umbilical arteries and vein. It's a very vascular vein, the placenta. So what I really want you to know about this chapter is what is the function of the placenta? Well, there's multiple things that the placenta does. The placenta is basically the life source of for the baby. The baby can't live without the placenta. So the placenta takes care of respiration, provides oxygen to the baby from the mom. It also provides nutrients and excretion of waste from the baby. It protects the baby. There's hormonal production within, and there's also like glycogen storage. Hormonal production, it's interesting if you've heard that some people after they have the baby, they will basically take pills of their placenta, and people swear that it actually helps with postpartum depression, kind of those postpartum variants of hormones. It helps with breastfeeding because the placenta does contain a lot of estrogen and progesterone. the fetal placental uterine circulation. So like everything is connected there. The oxygenated maternal blood brought to the placenta through the end spiral arteries. So the baby doesn't actually breathe in utero. It practices breathing, but it gets its oxygen from mom. It does breathe in the fluid, but does not breathe in any oxygen because baby is in a fluid-filled sac. So the mom's blood provides oxygen. The maternal blood enters the inner villus space near the central part of each placental lobule, and the maternal blood returns through the network of veins. So there's a huge connection between the mom, the placenta, and the uterus. The thin layer separates fetal blood from the maternal blood. The layer is composed of capillary wall, trophoblastic basement membrane, and thin rim of cytoplasm. And fetal placenta anchored to maternal placenta by cytotrophoblastic shell and anchoring villi. The oxygen-rich blood passes through the umbilical vein, which is interesting. And this is what another thing I need you to know for your test is that the oxygen-rich blood does not go through the umbilical arteries; it goes through the umbilical vein. So it's opposite of what we have in our bodies, if that makes sense. So the umbilical vein brings the oxygenated blood into the fetal abdomen. Some blood is going to the liver. The rest of it bypasses the liver from the ductus venosus, which is this little vein that connects the umbilical vein to the inferior vena cava. So the ductus venosus helps to bypass some of that blood from the liver. The baby doesn't need all that blood in the liver. It needs some in its brain, in the lungs a little bit, and the systemic arterial arteries. So the ductus venosus job is to shunt the blood. It continues into the heart through the right atrium, across the foramen ovale into the left atrium. Some of the blood goes from the right atrium to the right ventricle. It kind of just depends. The blood then passes into the left ventricle, ascending aorta, supplies the brain and upper part of the body through the brachiocephalic circulation. So it's pretty interesting. There's multiple areas within the fetus that we don't have that close after we're born, that are just miraculous, that help to make sure that all the places that need oxygenated blood are getting oxygenated blood. One of those is the ductus venosus. It turns into the ligamentum venosum in the liver when we're born. Unoxygenated blood from the severe vena cava passes into the right atrium through the right ventricle across the MPA, the main pulmonary artery. And a minor portion of blood from the right ventricle supplies the lungs. The lungs don't need a lot of blood, oxygenated blood, because they're just practicing. They're not breathing in oxygen. The majority of it passes through the fetal shunt, the ductus arteriosus, into the aortic arch. The aortic arch supplies some of the brain, and also the aorta takes it to the organs too. The fetal blood continues inferiorly to return to the placenta for respiratory and nutrient exchange, and by term, approximately 40% of fetal cardiac output is directed through the umbilical circulation. Here is an image of that. Now, you may or may not, which you may and you will, have to, in an essay for your next test, tell me the circulation of the fetal circulation. So this is something that I want you to be able to know. So I want you to study this. It's something important. So I will ask you how to tell me about the fetal blood circulation from the umbilical vein back to the umbilical artery. And there's multiple different pathways for that. So you'll have to know the different pathways. So the placenta is dedicated to the survival of the fetus. The maternal placental circulation may be reduced by a variety of conditions that decrease the uterine blood flow, such as severe hypertension. If the mom's hypertensive, the blood's not going to be getting to the placenta as much, and that could cause intrauterine growth restriction in the baby. Any kind of renal disease or a placental infarction, if there's just not the correct amount of blood flow going through the placenta, that can cause IUGR. Intrauterine growth restriction is what it says when the baby's not growing as much as they should within the womb. The net effect is that there is a reduction of flow between the fetal and maternal blood. The placental membrane is called a barrier because there are a few compounds unable to cross placental membranes in detectable amounts. So the placenta actually does protect from a lot of different things that the mom is exposed to. Some things do pass through. And a couple of those things that I just want you to be aware of are toxoplasmosis, some bacterias, um, some medications can pass through. There's actually a grading system of medication that is good to take and things that should definitely not be taken because of how it could slip through the placental membrane and affect the baby. One of those interesting things that I did not realize was Pepto Bismol. So if you're ever wanting to get pregnant or just, don't do Pepto Bismol because it's actually a X drug. It's a rated X, which is absolutely don't do it. And there are some compounds within Pepto Bismol that are very harmful to the fetus. I did not know this, but I was smart enough to look it up before I took it when I was pregnant. So there's different drugs that some drugs don't affect the baby and do not pass through. Other drugs do pass through. Also, some viruses and bacteria don't affect the baby and do not pass through. Others do. So it kind of depends on what that is. And there's a huge list. But what I want you to know is that the placenta acts as a barrier. It tries its best to protect the fetus from different exposure to things. So from the placenta, there is a chordal attachment, and the attachment of the cord is usually near the center of the placenta. That's where we want it. Abnormal chordal attachments to placenta are battledore and velamentous placenta, which we'll talk about in just a second. So you will see in a normal placenta, you'll see here's the placenta right here, and then you see a cord going in the center coming out of it. If it's on the side and not within the center of the placenta, it's considered a battledore placenta, which is a marginal placental cord insert, basically. So it's close to the edge of the placenta. The problem with this is the theory is that the baby is not getting as much vascular flow through the placenta as it would if the cord is within the center. A velamentous cord insertion, which we'll talk about a little bit more in detail in a couple minutes, is where the cord inserts into the membranes and not even into the placenta. So the vascular flow the blood has to pass through the membranes to get to the placenta. And this can cause growth restriction and can be dangerous to the fetus too. So these kiddos that have a velamentous cord insertion are watched closer in utero. The placenta normally implants on the anterior, fundal, or posterior lateral walls of the uterus. So it kind of just depends. I see a lot of anterior posterior placentas. If the placenta is on top of the fetus, which is considered anterior, the mom tends to take a little bit longer for the mom to fill the baby. If it's on the posterior, because the baby kind of has to kick through the placenta, which in turn is from, there's more nerves. And so moms don't fill as fast those babies. If it's on the posterior side, it seems like the moms can feel a lot of movement from the baby. Occasionally, the implantation will occur within the lower uterine segment, resulting in a condition called placenta previa. Placenta previa is basically where the placenta is covering the cervix or very close to it. And this can be dangerous just because of what we're learning about how vascular the placenta is. Um, if it gets in the way at delivery, it can cause hemorrhaging and bleeding of the mom. And I think this might have been why a lot of moms died in back in the day during childbirth because they didn't know this. And it's something that does occur. I see quite a bit. So I will teach you how to see those. So this is an anterior placenta. Look at this cute little baby, little profile of the baby. And the placenta is this hypoechoic mass right here, easy to see. And this is on top of the baby. So this would be considered an anterior placenta. This is a posterior placenta, which is on the bottom. So this is towards the skin of the mom. This is towards the spine. The posterior placenta is on the backside of the uterus. Now, there's multiple fetal membranes, the chorion, the amnion, the allantosis, and the yolk sac. The chorion originates from the trophoblastic cells and remains in contact with the trophoblast throughout the pregnancy. So it's closest to the placenta. The amnion develops at the 28th menstrual day and is attached to the margins of the embryonic disc. As the embryo grows and folds ventrally, the junction of the amnion reduces to small area of ventral surface of the embryo to form the umbilicus. So the expansion of the amniotic cavity occurs with the production of amniotic fluid, and around 16 weeks of gestation, the amnion and the chorion fuse. If the amnion and chorion separation extends beyond 16 weeks gestation, it may be associated with polyhydramnios, aneuploidy, and prior amniocentesis. So basically, there's two membranes, the amniotic sac and the chorion, and as the baby grows and more amniotic fluid continues to accumulate within the amniotic sac, the amniotic membrane grows, and then it fuses with the chorion, and then you don't really see the membrane. You see the membranes on the very slight edge of the placenta, but they're not as noticeable in the second trimester. So the amnion forms the sac that contains the amniotic fluid, and the sac encloses embryo and forms the epithelial covering of the cord, and most of the amniotic fluid from the maternal blood via diffusion across the amnion. In the first trimester, the fetus begins to excrete urine to fill the amniotic cavity. Yes, they swallow this fluid, then their kidneys work it through, and then go through the bladder, and then they pee it out. It's all, and it just continues. This baby breathes the fluid. It's all sterile, but it is kind of interesting how the amniotic fluid works. The fetus swallows amniotic fluid. This continues on throughout the pregnancy. So, what are the amniotic fluid functions? Why is it important to have amniotic fluid? Well, the first thing is it permits the fetus to room to move and grow. If the baby does not have enough fluid, they won't be able to form correctly. It assists in maintaining constant fetal body temperature. So it's a nice warm, I think it's 100 degrees or 99 degrees in there. Someone actually asked me that, and I was like, I'm not sure the degrees of the womb. I would think it would be pretty close to the mom itself, but so I looked it up, and I think it's just about 99 degrees. It's serving as a protective buffer for the fetus and allows the lungs to develop properly, which is a huge thing. The baby's lungs can't develop properly without amniotic fluid. If they don't have enough amniotic fluid and they're not breathing in enough amniotic fluid, the baby's lungs won't develop. If the baby's lungs don't develop, they can't live. They're not viable. And that will become a huge thing for you guys later on within the semester when we're talking about kidneys and how important all of these functions are and how they work together. The umbilical cord forms during the first 5 weeks of gestation and is surrounded by the mucoid connective tissue called Wharton's jelly. Now, Wharton's jelly does a really good job at making sure it's really slimy, and it makes sure that it doesn't knot the umbilical cord. So that's what Wharton's jelly does. It's a protective layer around the umbilical cord that's kind of slippery. So the intestines grow at a faster rate than the abdomen, and they herniate into the proximal umbilical cord around 7 weeks. This is totally normal, mid-gut herniation, and until the baby grows enough, and then they go back in around 10 weeks. The insertion of the cord into the ventral abdominal wall is an important sonographic anatomic landmark because the scrutiny of the area can reveal abdominal defects such as omphalocele, gastroschisis, and limb wall defects, which we'll talk about later. But basically, what this is saying, if for some reason the baby's herniated gut does not go back inside, it could be an omphalocele. If there is a defect other than the umbilical herniation and the bowel comes out by the umbilical cord, it's called gastroschisis. The normal umbilical cord has one large vein and 2 small arteries. You need to know that for the rest of your life. The single umbilical artery is found in approximately 1% of all singleton births and 7% of twin gestations. So sometimes you can have just one artery in one vein and not the normal 2 arteries in one vein. When that occurs, a lot of the times it's totally fine. We watch those babies a little bit closer, but it seems like congenital malformations are seen more in babies that have an SUA. This is where the cord goes into the placenta. This is the placental cord insert. And it looks like it's in the center, which is good. And this is the 3-vessel cord. It looks like a little Mickey Mouse sign. That's what I like to call it. And this is in a transverse look at the umbilical cord. So you can see the 2 small area circles are the umbilical arteries, and the big one is the umbilical vein. Again, with the circulation of the placenta, fetal circulation, placenta and the umbilical cord. Now remember, the umbilical vein is what carries the oxygenated blood, and the umbilical arteries are what carry the deoxygenated blood. So it's opposite of what we learn in our bodies. So let's talk about sonographic evaluation of a normal placenta. So the fetal surface of the placenta is echogenic chorionic plate coursing along the placental tissue, and it's found at the junction with amniotic fluid. So basically you'll see a white line where the placenta is correlating with the amniotic fluid. Now, let me see if I can show you a picture of this. It's basically this little white area right here. And it's just like all this, it's just a white little line that kind of borders the placenta, and that's the chorionic plate. The linear echogenicity further enhanced by a strong interface of the anion covering the chorionic plate. The second surface is the basal plate, the maternal portion of the placenta, which lies at the junction of the myometrium and the substance of the placenta. This is where the maternal blood vessels from the endometrium run behind the basal plate. Can be identified with sonography as early as 8 menstrual weeks. You can see a little bit of the placenta, but we don't really look too much and evaluate the placenta that much in the first trimester. We wait till the second trimester to really evaluate it. And it usually is hard to miss because it's a large area. It has homogeneous mid-level gray appearance between 8 and 20 weeks. So it's just a very nice, smooth mass. After 20 weeks, sometimes you can start seeing intraplacental sonolucencies and placental calcifications begin to appear. Just like us, as we age, we don't um, things start showing up like wrinkles. And it kind of is the same thing with the placenta. Um, Intraplacental sonolucencies and calcifications that weren't there before when the placenta was young begin to show up. Um, and pretty much by 40 weeks, the placenta is just done. It's had a good life, but it's like I'm done taking care of this. It's time for the mom to step up or something. I'm just being silly, but um yeah, that placenta, it's done by 40 weeks. The thickness varies with gestational age, but it usually is 2 to 3 centimeters, and the fetus is greater than 23 weeks. The normal placenta rarely exceeds 4 centimeters in the anterior to posterior measurement. So you need to know that. Here it is again. So this like echogenic area that's bordering the placenta right there, that's what I was talking about with the chorionic plate. Now, see these two different kinds of gray? This is the uterus, and then the placenta is right adjacent to part of the uterus there. So where those two basically interface, that is the basal plate. When you put vascular flow within this, it's going to light up pretty good because there's a lot of blood vessels that connect those two. Just like this. See that arrow right there? That is this white arrow. That is actually where the basal plate is. And this is the myometrium. So that's part of the mom's uterus, the muscular area. This is an enlarged placenta. If you look at it, it's 5.88 centimeters. You can also see that what we're talking about, these sonolucencies, placental lakes are what they are called. And the placenta just isn't as pretty. That tends to happen more after 20 weeks. Cystic structures representing large fetal vessels commonly observed coursing behind the chorionic plate and between the amnion and chorion layers. Here's more vascular flow behind the placenta. We want to see that. So the placenta sonolucencies that we've been talking about are referred to as placental lakes, and they're mostly just a normal finding. They may change in shape and size during course of ultrasound examination. If I see a very, very large one, I'll note it in the exam report. If frequently, blood flow will not be detected with color Doppler, and it's a real-time sonography shows slow swirling flow because it's just like an accumulation of blood. The placenta is separated from the myometrium by a subplacental venous complex. The veins can become very prominent, especially for the lateral and posterior placenta. So you'll see like a lot of vascular flow behind it. This is like just a gathering of blood here, another placental lake. You can see now this is a beautiful picture of the chorionic plate, and this is what we're talking about. It's fused with the amnion here because this is black is the amniotic cavity. So that's what we're talking about with the chorionic plate. So the placental position, you want to survey transabdominally, look at it sagittally from side to side, and then do a couple transverse images of it from inferior to superior. I want to make sure that I take an image of where the edge of the placenta is in relation to the cervical os, just to make sure that it's not low lying or a placental previa. Once I do that and I can determine where the placenta is, then I'll go ahead and look for the insertion of the cord into the placenta. And again, the reason that we do that is because we want to see it within the mid cord, the mid of the placenta. If it's not, it could be a marginal or battledore placenta or a velamentous cord insertion. The inferior edge of the documented to evaluate its relationship to the internal os, which I talked about. So this is a sagittal view of the uterus that reveals the posterior fundal placenta. That's normal. We want to see it actually fundally. further away from the cervix, I like to see it, the better. This is a transverse image of the uterus, and you can see that the placenta wraps around the wall. So this is more like an anterior right lateral placenta. And this right here, this is the cervix. So this is the lower uterine segment. And there is placenta covering the lower uterine segment here. So this would be a placenta previa. We will want to keep looking at this placenta throughout the pregnancy and make sure that it moves away from the cervix, which sometimes they do. Yes, you can still have fibroids while you're pregnant. This is a large fibroid that is adjacent to the uterus here. This is another image of the lower uterine segment. This is the placenta. I'm sorry, this is the placenta. The white arrow right here is the cervix. The placental edge is way far away from the cervix. So we can say that this is not a placenta previa. If the maternal bladder is full, the cervix could be falsely elongated. Normally, I don't like the mom's bladders too full because I feel like you can falsely get a placenta previa with them. So I usually have the moms empty their bladder before I do their anatomy scan. Normally, the implanted placenta may appear to be covering the internal cervical os in this case. So if I feel like the bladder is super full and the placenta is covering the os, I'll have the mom go to the bathroom and then I'll have her come back. I'll do the rest of the scan and then I'll look at the placenta again in relationship to the cervix. And about 75% of the time, the area resolves that I was concerned about, just because the bladder can cause the position to be false. If for some reason you need to get a better look at the internal cervical os when scanning transabdominally, you can tilt the patient back in a slight Trendelenburg position, the head slower than body, which is not comfortable for them at all. But this does relieve some of the pressure of the uterus on the lower uterine segment. And if there is a baby head down there, it kind of tends to get them out of the lower uterine segment so you can evaluate that better. But a lot of the times I just skip that part and I will ask the doctor if I could do a transvaginal ultrasound, because that's the best way to really evaluate if the edge of the placenta is near the cervix. It's also the best way to measure the cervix. I do not like to measure the cervix in transabdominally, just for the same reason that it can be falsely elongated, or just not as good an image. So if the anterior and posterior placenta do not appear to communicate, it could be an accessory lobe or a censuriate placenta. And this is when there's an additional placental lobe that are joined to the main placenta by blood vessels. So what you want to do in this case is differentiate the main lobe from the accessory lobe by locating the placental cord insertion site to identify the main placenta. There is a slight risk that the connecting blood vessels may rupture, or an extra lobe may be left in the uterus after delivery. That's when you want to make sure that you mention this in the exam. So the clinician should be notified. So the term migration is used to describe how the placenta changes position within the uterine cavity, which is what I basically said. It's just easier in layman terms to say the placenta moved away from the cervix. But the placenta does not actually migrate or change positions. The uterus grows, which I think sometimes that can change the position of the placenta. But this book has always had the theory that, because I've always wondered this, about this book. If this they say that the placenta position appears changed because of the physiological changes in the lower uterine segment. So the blood supply in the lower uterine segment causes the placenta in that area to atrophy and disappear. So the areas of rich blood supply toward the fundus and mid portion of the uterus causes the placenta to hypertrophy. So it says that the placenta that is in the lower uterine segment does not get as much blood flow, so it dies, and that causes the placenta not to be close to the cervix anymore. Now, I don't know how much about this theory I believe. Sometimes I feel like that's pretty far reaching for me. It more makes sense in my mind that the placenta, as the uterus grows, would also appear to change position. But in any case, this is what the book says. I will not quiz you on that because I'm not for sure. However, you need to know that sometimes when a placenta is low lying at 20 weeks, when you are scanning the baby doing their complete, when they come back at 30 weeks, a lot of the times the placenta is not in the same position and is not low lying anymore and not close to the cervix. If it's because that area of the placenta has died or the uterus has grown and the placenta has migrated, that is the question. But in either case, it most of the time moves away from the cervix. Oh, right. Anyway, Doppler evaluation of the placenta. The uterine arteries sonographically reveals high resistance flow pattern in the first trimester. And the second trimester, it should be low resistance. So let's see if I can. There's usually sometimes a notch that appears in the umbilical artery Doppler, but it usually goes away by 24 weeks. So abnormal trophoblastic invasion of the spiral arteries of the maternal uteroplacental circulation is associated with placental insufficiency, IUDR, preeclampsia, and placental eruption. So this is showing the blood flow within the placenta with a high resistance flow. So at term, the placenta has several characteristics at delivery. It measures about 15 to 20 centimeters in diameter, so it's very large. It's discoid in shape, weighs about 600 grams, and measures 4 centimeters in thickness. The clinician ascertains that placenta delivered intact to avoid complications of postpartum hemorrhage or infection. If some of the placenta is left, it's called I'm sorry, I just totally blanked on what okay, it's called retained products of conception. Wow. And so that can cause a fever, can cause infection. So it's very important that the whole placenta is delivered. Membranes of the amnion and chorion inspected in color and consistency, and signs of meconium staining or infection. Also look for meconium staining is where the baby actually has a bowel movement within the utero, and it could cause some problems with the baby's an infection with the baby. So it's important that they look for that. The length of the cord is noted. Short umbilical cords may result in traction during labor and delivery, leading to tearing of cord, abruption, or inversion of uterus. Short cords are difficult to diagnose within utero. Long umbilical cords more likely to prolapse, become twisted around the fetus, or tie in true knots. So you just need your cord to be just right. Reasons why the placenta would be extra big, or placentalomegaly, which is the scientific medical term for a big placenta, would be, and you need to know some of these for your tests: maternal diabetes, which is the huge thing, maternal anemia, thalassemia, Rh sensitivity, fetal maternal hemorrhage, chronic intrauterine infections, twin to twin transfusion, congenital neoplasms, and fetal malformations. Most of the time, it's because of diabetes. It tends to make the baby big and the placenta big. Why there would be a small placenta would be intrauterine growth restriction, an infection, or aneuploidy. So, placenta previa, the definition again, and this is important for you to know, and you will be tested on this, is the implantation of the placenta over the internal cervical os. Normally, implants in the body are fundus of the uterus. In 1 in 200 pregnancies, placenta implants over near to the internal os. So, you actually see it quite a bit. You have an increased risk of this if you had a history of cesarean delivery. So these are your different kinds of placenta previa. Complete previa, obviously, those most of the time do not move. Those are implanted down there, and that's just how it's going to stay. These moms that have these are delivered early and by C-section, of course, and we monitor the baby closer and the placenta. Um, because it would be dangerous if the mom delivers the placenta first because of the vascularity um, of it, and the mom could bleed out or hemorrhage. So that can be a serious situation. Partial previa is just where a little bit of it covers the cervix, and those sometimes can move, sometimes they just stay there. This still, mom would deliver early with this for the same reasons as the complete previa. A marginal previa is a little bit different than a partial because it's not covering the os, but it's right on the edge, and it's still considered a previa. A low-lying placenta, which is what we see most of the time, and those tend to either migrate or that area dies, whatever, depending on which book you read. But either way, when they're low-lying placentas, we check back within like about 4 to 5 weeks, 4 to 6 weeks, to see if the placenta has changed positions or moved. Um, and what we consider a low lying placenta is a placenta edge to cervix measurement that is less than 2 centimeters. Multiple factors are associated with the placenta previa. If you're older than 35, which is advanced maternal age, it's considered. Um, you have a higher risk of having a placenta previa. Smoking can, cocaine abuse, prior placenta previas. If you already had one, you have a higher chance. If you had multiple babies, prior C-section or uterine surgery. And these are the complications of a placenta previa: preterm delivery, maternal hemorrhage, increased risk of placental invasion into the myometrium, increased risk of postpartum hemorrhage, and intrauterine growth restriction. Clinically, a mom will present with painless bright red vaginal bleeding in the 3rd trimester with a complete previa. 25% of the patients will present with bleeding during the first 30 weeks, 20% of cases associated with uterine focal, myometrial contractions, abnormal light also associated with placenta previa. So basically, if the mom is bleeding throughout the pregnancy, that could hint off of placenta previa. This is not a great picture, but this is the baby's head. This is near the cervix, and the placenta is totally covering the cervix. Here's a better picture here. This is the cervix, this area. Remember those lines that I'm showing you in our pelvic scanning class? And then this whole mass is the placenta that is covering the cervix. Here is the placental edge covering, so this would be more of a partial previa. This is a transvaginal ultrasound too. Here's another one. This looks like a low-lying placenta. This is the placental edge, and they measure it to the cervical os, which is right here, and it's 1.63 centimeters, so this would be considered a low-lying placenta. So a vasoprevia, those are potentially life-threatening fetal complication and occurs when the large fetal vessels run in fetal membranes across the cervical os. So the vessels at risk of rupture and life-threatening hemorrhage. So basically what that means is that there's blood vessels that run across the cervix. So if the baby had a vaginal birth, those blood vessels would be um, ruptured and it could result in a life-threatening hemorrhage. So the most common causes of vasa previa would be a velamentous insertion of the umbilical cord into the placenta membranes, which cross over the cervix. So if you do not see the placental cord insert within the placenta and you see a velamentous insertion, which is the cord inserting into the membranes, you definitely want to check for vascular flow over the cervix. The other time would be if there is a accessory lobe present and the connecting vessels transverse the cervix. So if you have two lobes, you remember your anterior and then a smaller posterior lobe, and the blood vessels that connect those two are crossing over the cervix. Those are the most common reasons why you would have a vasa previa. When delivery is imminent, unsupported fetal vessels prone to tear as the cervix dilates can result in basically the baby not being able to breathe. Rapid cesarean delivery may prevent fetal demise. This is an image of a vasa previa. This is the cervix down here. There's two accessory lobes or two placental lobes there, and there's blood vessels that connect, although not a great picture. Again, not the greatest, but this is showing that the vascular flow of the placenta. This is the picture that I put in, which I think is a lot better. But okay, so this is transvaginal ultrasound. This is the cervix here. You put vascular flow and you see this artery veins running across the cervix and they don't move. This is considered a vasa previa. So placental invasion, it's the abnormal penetration of placental tissue beyond the endometrial lining of the uterus. Variants of placenta invasion exist. The placenta crata is where the chorionic villi attach to the myometrium without muscular invasion. So placenta crata is where the placenta does not stay where it's supposed to be and it grows past its little border into the uterus. The placenta increta is further extension of the chorionic villi into the myometrium, so that is even further extension. And placenta percreta is penetration of the chorionic villi through the uterus. Sometimes I see placenta that even grows into the bladder. The placenta increta results from underdeveloped decidualization of the endometrium. The association of placenta previa reflects the thin, poorly formed deciduas of the lower uterine segment that offers little resistance to deeper invasion of the trophoblast. So if you have a previous cesarean scar, it permits more for trophoblastic invasion. So patients that have had a C-section before are at higher risk for a placenta creta. High maternal mortality morbidity is associated with placenta creta percreta just because of the risk of hemorrhage. So this is the placenta. Usually you would see that line of the myometrium and the placenta. You remember that basal plate. Sometimes the placenta just keeps on growing into the myometrium and extends through the myometrium, and that is considered placenta creta. See how close the bladder is? Sometimes the placenta doesn't stop at the uterus and its tissue continues to grow into the bladder right here, the big black hole. This is an image of the different invasions. The cretas are most common, which is good because it's still not great, but it's better than the other forms. Sometimes if these other forms occur, the mom will have a hysterectomy after the baby is born. So usually you have that nice decidua, the basal plate that's separating the placenta from the uterus, and in a creta, that part is gone. In an increta, it continues to grow within the myoatrium, and the percreta, which is the least common, it grows past the uterus. Sensoriate placenta, the presence of one or more accessory lobes connected to the body of placenta by placenta vessels. It occurs 3 to 6% of pregnancies. Most of the time, if it's out fundal and in the fundal uterus, and there's a large anterior placenta and a small posterior placenta, and it's not, the membranes and the vessels are not crossing the cervix, and the doctor knows, it's not a big deal, honestly. Um, but where it can be a big deal is if the doctor does not know and there's some placenta that is left in after delivery. But the major big deal is if this would be occurring with a vasa previa. And the reason this would be a big deal is these vessels that connect the accessory lobe to the big placenta, if they are crossing the cervix and we don't find that, that is scary, because that could cause fetal demise and a maternal hemorrhage afterwards. That's why it's always important to be thinking about this stuff when you're scanning. I always like to put vascular flow on the lower uterine segment. So here's anterior accessory lobe and a large placenta in the posterior side. So a circumvallate circummarginate placenta, they're where the attachment of the placental membranes to the fetal surface of placenta, rather to the underlying villus margin. So basically, the placenta tends to flip up, and I'll show you. The results in placenta villi around the border of the placenta, not covered by the chorionic plate, and is diagnosed when the placental margin is folded, thickened, or elevated within the underlying fibrin, associated with PPROM, with premature rupture of membranes, preterm labor, IUGR, and placental abruption. So it's basically this portion, the little edges that are the arrows here, they should be down on the maternal surface of the uterus. Instead, they're flipped up. And this can cause those issues that we just talked about. So you would want to make sure that you are just noting this so that we can watch the baby closer. Okay, so we're getting close to the end, but the next thing I want to talk about is placental hemorrhage. And it may occur within or around placenta. It's more commonly seen than a placental abruption. And it just usually occurs a lot in the first trimester, and it refers to bleeding from the placenta from any cause. So it can be retroplacental, subchorionic, subamniotic, or intraplacental sites. The echogenicity depends on the age of the hemorrhage. If it's newer, it's more echogenic. If it's older, it's less echogenic. Um, the big one and the scary one is called placental abruption, and it refers to the separation of the normally implanted placenta prior to term delivery. So the placenta detaches from the uterus prematurely, and it occurs in 1 in 120 pregnancies. A lot of pain occurs with this and bleeding. It Retroplacental abruption results from the rupture of spiral arteries and is a high pressure bleed. It's associated with hypertension and vascular disease, and a hematoma is seen between the placenta and the uterus. If blood remains retroplacental, patients may not have any vaginal bleeding, but they could have pain. Acute sonographic findings show thickening of the placenta, and older hematomas tend to be hypoechoic compared to the placenta. So you'll see where this should be just that myometrium, you'll see a large yucky area behind there. This is placental abruption, a hematoma behind there. It won't have vascular flow. So I always like to put vascular flow on the placenta to show that it's connected to the myometrium. If I see something like this behind the placenta, um, and the patient's having clinical signs, it tips me off that this could be a placental abruption. Now, I always talk about this. I don't know, you guys are probably who has seen Twilight before, but Bella in the last one, when she was pregnant with the half vampire baby, she came became in a lot of pain. She bends down, she comes back up, and the placenta tears away from the uterus. Do you guys remember that? If you don't, you might need to go watch Twilight again. Or something, just for the fact that when I saw this, I was like, she's having a placental abruption. She was in a lot of pain. She started hemorrhaging. Edward had to save her by turning her into a vampire. Basically, it is a life-threatening situation when you do have a placental abruption, and the baby barely made it too. So anyway, I always use that as an example for placental abruption because it's really that's what happened to Bella. If you didn't know what a placental abruption was, you'd probably be like, why, what happened? She just bent down, and when she comes back up, she's dying. And it's probably because the placenta tore away from the uterus and there's a lot of blood loss. You can also have marginal abruptions. Those are the most common types. They're known as subchorionic bleeds. They're pressure bleeds. Sometimes the mom has a little bit of pain and bleeding, but they usually arise from the edge of the placenta instead. And so they're not as life threatening, basically. Subchorionic hemorrhage accumulates at the site of the separation of the placenta and may continue to bleed after initial hemorrhage. Um, I usually scan if I see like a marginal area and a hypoechoic area on the edge of the placenta. I'll make sure to take a note of it. Here's a little marginal abruption. Most of the time, these babies still do okay, but it is something that once you need to be noted. You can also have intervillous thrombosis, and that's just the presence of thrombus within the intervillous spaces, and it occurs in 1/3 of pregnancies, so it's pretty common. There's usually no risk to the fetus, but you will see like little hypoechoic areas within the placenta. Kind of looks like this in the placenta. Placental infarcts are focal discrete lesions caused by ischemic necrosis, and it's found 25%. Again, usually no clinical significance. Okay, last thing that is important is placental tumors. Remember gestational trophoblastic disease or molar pregnancies? They can be benign and malignant. If they are malignant, it could be a choriocarcinoma, which is the invasive mole, which is a cancerous tumor that metastasizes easily. So, if gestational trophoblastic disease is seen in the first trimester, the clinical signs are very hot nausea and vomiting from elevated HCGs, vaginal bleeding, and uterine size larger than dates. Partial or incomplete moles usually have a triploidy karyotype, and fetal tissue is often present. So, when you have a partial mole, you'll have that molar pregnancy, but you'll also see a fetus. But the fetus do not have normal karyotype. They have triploidy. Triploidy, usually those babies pass away in the first trimester. They clinically may present with vaginal bleeding, and malignancy is diagnosed in 2 to 3% of these moles. There's that cluster of grapes appearance, like those, all those little areas within. This is a complete mole. A chorioangioma is a benign vascular tumor of the placenta. It's the most common tumor of the placenta. You'll see it. They're usually small, but they're usually growing on the chorion. Some fetal complications that can occur if they're very large are polyhydramnios, hydrops, anemia, cardiomegaly, IUGR, and demise. This is, you'll just see like a extra mass on the placenta basically, and most of the time they're usually chorioangiomas. So a little bit about the placenta and the multiple gestations. So let's talk about this. In a monozygotic twins associated with all three types of membranes, but if a baby is a dichorionic, diamniotic, so they're di-di, they have their own sac, they have their own chorion, they're going to have two placentas. If they're monochorionic, diamniotic, they have their same two separate sacs, but one placenta. So you can tell if it's going to be one or two placenta from this chorionic term here. If it's dichorionic, it's two placentas. If it's mono, it's one. So monochorionic, one placenta, one sac. Those are considered mono twins. So di twins, they're probably dizygotic, which means that they're fraternal. They're not identical. So diamniotic, dichorionic twins have two placentas. It can occur sometimes in monozygotic, which is identical twins, if division occurs pretty fast, but it's not very likely. If twins are sharing one placenta, they're most likely monozygotic twins, which means they're identical twins. They come from the same embryo that split. This is the difference. Dizygotic twins, fraternal twins, they're derived from two zygotes, which means they have two embryos implanted. They have their own genetic makeup. They most likely came from two different eggs. So they're kind of just like siblings that are sharing the womb at the same time. And probably the safest twin to have because they have their own placenta, so they're not having to share blood flow or anything. So monozygotic twins, those are the identical twins. So they're derived from one zygote. So they have basically almost the exact genetic makeup because they just split from one zygote. If they split super early, they could potentially have two different placentas. But most of the time, what happens is they have one placenta and they share it. This can cause issues later on in the pregnancy. A monochorionic, monoamniotic, those are the least safe babies to have just because you are dealing with, they're even separated. They don't even have their own sac. So they're just all in one sac, which could lead to cord entanglement. So the risk involved for monochorionic are placental vascular anastomosis. So that babies could start sharing more blood than they should. Those are the risks for monodi twins. Monoamniotic, where they're sharing a sac too, entanglement of the cord is a huge thing. So this is showing that you can have separate placentas. You can have one baby that has a placenta anterior, and you can have one baby that has a placenta posterior, and they both be diamniotic, dichorionic. Or you could have a dichorionic, diamniotic pregnancy that just have fused placentas, so it looks like a very large posterior anterior placenta. Here's another look at this. So dichorionic means two placentas. So they each have their own placentas. This is probably the safest. This is one placenta. They have their diamniotic. They each have their own sac, which is good, but they're sharing that placenta. Monoamniotic, they are sharing the same sac and the same placenta, which is the kind of scarier one to have. One more picture of the twins, and we'll talk about twins a little bit later, a little bit more in depth, but just kind of talking about their placentas right now. Sharing, least safe. Monochorionic, diamniotic, those are most of the time identical. Dichorionic, diamniotic, most of the time they are fraternal, and most of the time fraternal. And I promised you a picture of my dog. So Winnie says, good luck with this placenta chapter. I know it's hard, but you can do it. All right. Have a good day. Bye-bye.